Yeah. Sam. There we go. Yep, you are.
Hi everyone, I will start my presentation by briefly explaining what migraine is. So the Global Burden of Disease report found that migraine is the second most common cause of disabilities. It is a neurological disorder that is affecting about 14% of global population and 20% of Australians. It is more common in females compared to males, especially at the age of 25 to 39 years old, which coincide with the normally peak productivity period. Migraine is characterized by episodes of headache that could last between 4 hours to 3 days, and the headache is usually pulsating and at moderate to severe intensity. It is usually, but not necessarily unilateral, and the headache can also be worsened by routine physical movement. Migraine can be associated with nausea, vomiting, and hypersensitivity to light, sound, and smell. And it can also come with aura during or without the headache. And this aura can manifest as visual disturbances and difficulties in sensory, motor, cognitive, and speech function. Migraine can occur in phases. So as early as 3 days, the prodrome phase may start. This is where the patient may experience non-headache symptoms such as photophobia and nausea. And then it can be followed by the aura and headache phase. And after that, the patient may enter the postdrome phase, or they call it migraine hangover. Okay, so this is where the patient may continue to experience the non-headache symptoms before they can truly be free from all the symptoms. So we can see here that migraine is not simply a headache, as it can come with a variety of discomfort for quite a long period of time. So currently, migraine is assessed based on these 3 elements. So it is diagnosed based whether the person has the specific criteria, such as listed here in the International Classification of Headache Disorder. And it is ruled out by general physical examination and supported by headache diary and headache questionnaires. So because of due to the complexity of migraine, the patient-reported outcome measures are the main critical instrument used to evaluate migraine. But these measurements are also prone to recall bias, so it may influence the management strategy. So why is migraine complex? Apart from the various spectrum of symptoms that I mentioned earlier, we still don't know what exactly trigger migraine to occur and recur. So what we know so far is that the unknown trigger could have interacted with factors such as stress, sex hormone, genetics, and in those with pain control defect mechanism and initiate migraine. But when migraine happens or resolve, imaging studies found that in general, there is some part of the brain in people with migraine that show increased neuronal activities. These include the activation of the trigeminal vascular pathway that carry nociceptive signals to the higher part of the brains and the cortex that lead to migraine pain and its associated symptoms. So the hyperexcitability of the brain parts may have released certain neuropeptides that trigger the activation of the trigeminal vascular pathway. So currently, calcitonin gene-related peptide, or CGRP, is identified as one of the key neuropeptide involved in migraine pain. This is due to its presence along the trigeminal vascular pathway and its involvement in migraine pain perception and termination. And now that there's also CGRP modulating treatment that has been found to be quite effective in treating migraine, even though not to all patients. Okay, So we know now that CGRP is involved in migraine pain. So what is the connection with the ocular surface? So the red dots here illustrates the components of the trigeminal vascular system that involve in migraine pain. So the corneal nerves comes from or originate from one of the components, which is the trigeminal nerve from the trigeminal ganglion. And then CGRP is mainly released by the A delta and C type fibers, and these fibers are abundant in the cornea. In investigating CGRP in migraine patients, studies found that there's also high concentration of CGRP in tear film compared to in blood in people with migraine. And this release could be mainly from the corneal nerves. And then there's also studies that found corneal nerve morphology in people with migraine is different. So based on these findings, it shows the potential for the corneal nerve to be a biomarker for migraine. So we hypothesized that corneal nerve characteristic is different in people with migraine. And to test the hypothesis, we evaluated the corneal nerve of patients with migraine and without, and to see how the cornea could give an objective assessment for migraine disorder. We recruited migraine patients from Prince of Wales Hospital, and we categorized the patient having episodic migraine or chronic migraine based on the number of headache days that they had in a month. We excluded those with systemic conditions that are known to cause neuropathy, such as diabetes, multiple sclerosis, fibromyalgia, and B12 deficiencies. And we also excluded several other criteria, such as listed here. For the corneal nerve assessment, we conducted in vivo confocal microscope, and the nerve morphology is was evaluated using automated software, which is the ACC metric software, using the established protocol. And for the statistical analysis, we conducted ANOVA to identify the differences between groups. So for the analysis, we recategorized the migraine patients according to group of episodic migraine, chronic migraine, and CM to EM. So the CM to EM group is a group of patients, migraine patients, who were previously diagnosed as having chronic migraine and now having episodic migraine after receiving treatment. So our results show that the corneal nerve morphology in people with migraine is significantly different compared to those without migraine, specifically at the inferior wall region of the cornea. So the inferior wall is actually located here, around here, is like slightly nasal and inferior to the corneal apex. It is where there is a distinct, unique features of the corneal nerves. So for our studies found that the corneal nerve fiber density and corneal nerve fiber length in people with chronic migraine is significantly lesser compared to those with episodic migraine and healthy controls. And we also found that the corneal nerve morphology is not much different compared between episodic migraine and CM to EM group. So the picture here shows the corneal nerves of our healthy control and EM episodic migraine patients, chronic migraine patients, and CM to EM patients. From the results of our study, we learned that the reduction of the corneal nerve morphology in chronic migraine patients compared to episodic migraine patient and healthy controls may reflect the impact of variable frequency of migraine attack to the corneal nerves. And the non-significant difference between the episodic migraine patients and CM to EM group is consistent with the treatment-driven effect as shown by the corneal nerve architecture. So in conclusion, our results highlight the potential for the corneal nerves to be an objective biomarker for migraine severity and progression. And therefore, this could also, the corneal nerve could also be a support measure in evaluation of migraine diagnosis and treatment response. Moving forward, we will further investigate the potential by looking at the association between the corneal nerves and current standard measure of migraine. One of it is migraine disability assessment or MIDAS questionnaire. MIDAS questionnaire is one of the outcome measures used in evaluating migraine condition in migraine clinical trials. So our early findings show that the migraine disability is significantly correlated with the reduction of corneal nerve fiber density. And as our results also show that the corneal nerve may be impacted by a frequency of migraine. So we will look at how the high and low frequency could have affected the nerves, and also how we're also looking at the long-term effect of what could be the changes on the ocular surface after receiving migraine treatment. That's all for me. I would like to thank my study participant, colleagues and supervisors and Alcon for their intense support of the study. Thank you.
Thanks. Thanks very much, Amalina. Can you start by telling us what was your role in the study?
I'm a PhD student where for this study, I basically involved in designing part of the study procedure and then collecting the data, seeing migraine patients as well, and then do the data analysis and involved in the ethics, whatever necessary as well. Yeah.
Thank you. Questions? Anka.
Thank you for the lovely presentation. What I would like to know is you talked about your CGRP levels in the tears, and then you showed us results of the nerve findings. How are those two related?
Okay, so as I mentioned earlier, the CGRP could studies found that CGRP is highly is really affected in migraine, and then in terms of the ocular surface, CGRP is mainly released by the fibers that are abundant in the cornea. So the nerves could be impacted by the release CGRP. So it's one of the part of our study as well. We will look further. We will see the association between the tears. We are looking at the concentration of CGRP in tears, and then we will look at how it is associated with corneal nerves. That is our future analysis as well. Yeah. Because we are collecting tears and looking at the corneal nerves images as well. Yes.
Has there been any hypotheses as to why the corneal nerve density might reduce in the context of migraine?
Why the corneal nerve density is
So
reduced?
you're showing that there's reduced corneal nerve density with migraine. Is there any hypotheses as to why this might occur?
Thank you for the question. The exact mechanism, it's still not known. But what we know so far regarding the fiber density and the corneal nerves in condition. For example, in diabetes, they associated it with the inflammation. So this could relate with the migraine as well, because migraine, some part of mechanism of migraine is neurogenic inflammation, but it's just part of it. It's not like the whole cause of migraine. So the neurogenic inflammation could affect the nerves as well, such as in diabetes. But we don't know, there is no maybe preclinical studies or what to really confirm that it's happening. Yeah, it's clear.
So you performed all of these confocal microscopy assessments yourself. Were you blinded to the diagnosis in terms of episodic chronic migraine or normal control, or did you know who they were?
When I do the procedure, I know what they have.
Yeah.
But then during the image analysis, I basically just do it, the analysis. So we are not sure what is the diagnosis until after we analyze the corneal nerve morphology. Yeah, that's it. But not
I see.
hundreds.
You acquired the images, but then you analyzed them in a blinded fashion. You blinded yourself.
But
okay.
Yeah.
Right. And then the images you actually showed, though, those were not the images from your patients? Those
My
were from somebody else?
No, my patients.
Oh, okay. You
Yeah.
had another reference underneath. That's why it was
Oh,
a little
okay.
confusing.
So
Yeah.
for example,
Yeah, right there.
yeah, image source here is just this image corneal nerve.
Oh, for that one. Yeah, those are your.
But
got
the
it.
rest is all our patients. Yes.
Thank you.
Okay.
Yeah.
Thank you.
All right, thank you.
It's Chris.
Yes.
Sam was going to come and help. If she's out there, she.
Are we ready for me to begin?
Was that? No.
Sorry, are we?
Zoom.
Yep.
Zoom.
So Sam's coming and she'll do it from her laptop.
Fantastic. Okay, thank you. Okay. So the second speaker, Chris Bull, I'll introduce in a second. He's going to zoom in. He's in the conference.
I'm sorry, Sam. You've disabled me from sharing my screen.
Yeah, there is. Okay. Chris, can you see us? Can you hear us?
Yep. Sorry, I think you've disabled me from sharing
Chris, you
sharing
should
the
now be
screen.
co-host and be able to share slides.
Okay, great.
Chris, I'm not sure if you've heard my intro, but you've got 10 minutes and then 5 minutes of questions. Is that okay? So you'll
Yep,
hear
that's
a
no-
last type of 10 minutes, okay?
Yep, that's no problem. I'm really sorry to be a bother. I can't share my screen screen with you.
I'll see if is Sam trying to share the screen.
Can you now,
no.
Chris?
Yep.
Yep.
Cool. Thank you.
Okay. Thank you. Okay. So today, once again, I'm really sorry that I'm not able to make it in person. What I really want to talk today is the relationship between obstructive sleep apnea, systolic blood pressure surges, cerebral small vessel disease, and cognitive performance. It's estimated that there's about 1 billion people worldwide with obstructive sleep apnea. So I assume I'm probably talking directly to quite a number of people today. Obstructive sleep apnea is a restriction or obstruction of breathing in the upper airway during sleep. This is typically around the nasal pharynx region. And the first line treatment for sleep apnea is something called CPAP, which I'm sure we're all somewhat familiar with. CPAP is extremely effective at reducing apnea. However, it's very poorly tolerated. So up to about half of the people that are on CPAP will discontinue use within the first year. And sleep apnea has been linked to the increased risk of various different things, most namely cardiovascular diseases and reduced cognitive functions. When we talk about sleep apnea management, what we often neglect to talk about is the neurocognitive consequences of obstructive sleep apnea. Sleep apnea has been linked with various different neurodegenerative disorders. This means both earlier onset and increased prevalence in the sleep apnea population. Because we lose such a large amount of people to treatment, we have a very large untreated and undertreated patient group. So as a result, many of these people remain at high risk of brain injury and cognitive decline. And this is something that we almost never talk about, but we really should be talking about more often. Sleep apnea has also been linked to something called cerebral small vessel disease. And if you have a look at the figure on the right, this is essentially damage to the smaller blood vessels and capillaries in the brain. And this can take a number of different pathologies, and I'll get to that a little bit more later. And when we talk about the causal neural injury, the causal mechanism of neural injury in OSA, we quite often make a number of assumptions and we don't really understand exactly what's happening. A lot of studies suggest hypoxia is the cause of injury, and hypoxia is obviously the drop in oxygen saturation that occurs with respiratory events in sleep apnea. Something that we do know that happens is when we have these respiratory events, we have a corresponding rise. So this is a paper from way back in 1995. They were monitoring blood pressure with an arterial catheter. This is quite an invasive procedure, and thankfully, we don't have to do anything like that anymore. So we now have a cuffless instantaneous blood pressure monitoring. So in this particular study, we used a Somnotouch for overnight instantaneous blood pressure. Our study protocol was quite advanced. We recruited patients that were untreated for obstructive sleep apnea in midlife, with the assumption that these people would have had obstructive sleep apnea for a number of years before our study began. They underwent overnight sleep study with blood pressure monitoring, plus neuropsychological assessment, as well as an MRI. In this talk, I'm mostly going to be focusing on the blood pressure and sleep, as well as the MRI findings. So this is a very interesting figure and one that we have never really seen before. So in the top panel, we have the systolic blood pressure overnight. And we've marked out the various different systolic surges that occurred throughout the study. And I just want to kind of stress just how high these surges are getting to. So they're getting to some quite alarming systolic levels, and they're just occurring very, very frequently. In the bottom panel, we have participant sleep architecture. So they do have severe sleep apnea. That's indicated by all of these different respiratory events that are occurring. However, they have a remarkably preserved sleep architecture. So they get all the way from stage 0, which is wake, down to stage 4, which is REM. And I just want to bring your attention to this one particular region here. This is in stage 4, so in REM sleep. You can see there's quite a number of surges, and there's also quite a number of events. So if we look in this a little bit finer detail, we can see that these surges keep occurring frequently over this particular period. And once again, they get to quite alarming levels. And then when you compare that into the bottom panel, so the surges in purple, you can see how these relate temporally to all of the different obstructive sleep apnea events that are occurring and how they're linked or not linked, as the case may be. We also monitored hypoxic burden. So this is a way of quantifying the frequency of magnitude and duration of oxygen desaturations that occur in the overnight study. I really can't get into the maths of all of it, but if you come and find me at some point, I will talk your ear off about all of the maths that's involved. To assess cerebral small vessel disease, we use something called the STRIVE protocol. So this is a scale from 0 to 4, with 0 being 0 CSPD. And you get marked 1 point for the presence of each of these different presentations of CSPD for a maximum score of 4. Additionally, we looked at various different brain metabolites for markers of both inflammation and energy. And we did this in both the grey matter and the white matter. In our study, despite our best efforts, we were slightly unable to match our patients on age. However, we were able to match the participants on almost all of the other demographic variables, including cardiovascular risk factors. So the AHI, or apnea-hypopnea index, is the score of sleep apnea severity. So thankfully, our control patients did not have sleep apnea. To get into the interesting findings, we confirmed a lot of research. So obviously, our sleep apnea patients had a higher hypoxic burden, which means they had more frequent desaturations that went for longer durations and a deeper depth. What was very surprising is blood pressure surge frequency did not differ between the sleep apnea group and the non-sleep apnea group. And then when we look into how this relates to the markers, we found a really distinct pattern that emerged. It seems like the hypoxic burden, which is the classical understanding of neurocognitive injury, occurred mostly in the grey matter, while the blood pressure surge index had most of effect in the white matter. And this is suggesting that these are perhaps two different pathways. And then when we looked at how this compared with the CSVD, the cerebral small vessel disease, we found that only blood pressure surge frequency was able to predict significantly the severity of cerebral small vessel disease. This was not present in the classical understanding of the hypoxic burden. So what does this really mean? Well, this study is suggesting that there's perhaps two different pathways. We're not trying to invalidate the hypoxic burden. We think that that definitely exists, and it's definitely something to be mindful and watch out for. But this seems to be influencing mostly the grey matter. And conversely, this novel metric, this blood pressure surge frequency, it seems to be influencing the white matter. So this is really suggesting that those smaller blood vessels, those capillaries in the brain, they just get overwhelmed with these repeated large scale, large amplitude blood pressure surges that are occurring very frequently throughout the night. We believe that this mechanism of injury may be modulated through cerebral small vessel disease. And this is actually quite an important finding. So these blood pressure surges, they may be treatable with existing medications. So we may essentially be able to deal with this problem without developing any new medications. And another important thing is that none of the participants that we had in the study had any symptoms other than having obstructive sleep apnea. So this really suggests that we can't ignore this neural injury. It's invisible to symptoms, and it's existing silently and progressing silently before we're made aware of it. We're looking into whether or not blood pressure monitoring instantaneously should be incorporated into overnight studies for the utility and how it can be associated with neural injury. This is probably many years away from being the case. As for limitations, this is a study in progress. We're very, very proud and very, very happy to share some of our initial findings. But we're still recruiting and we're still collecting data for this study. And we were dealing with a relatively novel technology with cuffless blood pressure monitoring, and there were a few kinks to work out. But it was a very useful, very, very useful tool to have. So if I can leave with one message from today, it's if you have sleep apnea or if you know someone dear to you that has sleep apnea, please try not to neglect the brain. It's something that we've failed to do to really educate about the neurocognitive risks associated with sleep apnea, and it's the most. So thank you very much for the opportunity to present today. Once again, I'm very sorry that I wasn't able to be there in person.
Thanks very much, Chris. Now, Chris, you've got a few minutes for questions. So I'll just see if there are any questions from the audience.
Hi, Christopher, can you hear me? Okay. Hi, thank you for your lovely presentation. I just wanted to ask something about your blood pressure technique. So you told us that it's a new technique and that it's cuffless, but do you know how well it is correlated with the actual non-invasive blood pressure? And my second question would be, do you know if people with sleep apnea during the phase of occlusion, did you try to come up with another index apart from the surge index to see if you could maybe only investigate the phases of sleep apnea to come to better results? Was that clear? Sorry.
I'm sorry, I don't think I really understand the second question.
Yeah, so the first question is regarding the technique, and the second question is, could you maybe change the way you analyze your data to see if you could use the patients as their own controls and compare the phase in sleep apnea to the phases without sleep apnea?
Oh yeah, sure, okay. This question. I possibly need a whole other 10-minute period to talk about it. We're dealing with a technology that's it's calculating blood pressure from post-transit time. And this is a technique that is very, very good for what it does, but it does have a number of inherent limitations in it. Essentially, to answer your question, the calibration tends to drift during the overnight study. So that's why we really focused on very short-term measurements. So we weren't trying to characterize the blood pressure profile in the overnight study. So some studies will talk about how the blood pressure will dip overnight or they will rise overnight. And this has a number of different consequences on cardiovascular risk factors. However, due to the limits in this technology, we weren't able to do that. So we were focused on very short-term recordings. So, 30-second increments to get these surges and to get the amplitude of these surges, which we had a lot of confidence were accurate readings. To answer your the second question, it actually does get a little bit more complicated. So the heuristics of sleep apnea change a lot during the various different stages of sleep, and it even changes between early night, midnight, late night. And it's to do with the physiology of the various different phases. So you tend to have a lot more sleep apnea in REM. You tend to have a lot less in the deeper stages of sleep, so stage 3. It is quite difficult. It is quite simple in some of the patients to isolate various different regions where they don't have any events and then compare it to other regions. But there's kind of a lot more at play than just the blood pressure. It's we may think that we're monitoring one thing, but we're really monitoring another thing. Be it the collapsibility of the airway or something like that. It's kind of unrelated to the blood pressure. So I do see your point, and I do think that it's a good thing to look into. I would just have to think really carefully about how to design the study to make sure that we are measuring what we think that we are and not something else inadvertently.
One more question.
Oh, I gotta pick one. I'm gonna pick one, do it. Your controls, where did they come from and why are there so few of them?
Good question and good point. The controls were just kind of recruited for the study blindly. They weren't part of any database. They were just people that we were able to, they reached our flyer or they reached some information and they approached us for the study. It's obviously a limitation, and that's one of this is a study in progress. And that's one of the key recruit roles. But I definitely acknowledge that this is a limitation.
No, that's okay. But they were matched for presumably hypertension and BMI. So I'm guessing they're actually closer to the OSA patients than maybe you wanted. And did you give us the STRIVE scores for both groups? Did you? I may have missed it. Did you actually? It was in your methods, but I didn't see it.
No, I mean, there was only so much that I could present.
Okay. Did they differ
we did.
That's okay.
Trying to think back on it. I don't believe there was a significant difference between the OSA and control group in the STRIVE. That's kind of an interesting finding in itself, whether you want to say that that's due to the blood pressure surges or the sleep apnea. I'm really hesitant. It was a correlation. I don't want to put too much into causation. But yeah.
That was the point. Yeah, thanks.
Thank you very much, Chris. Thank you for that.
No problem. Thank you very much.
Our next speaker is Katarina, who's talking to us about proving the diagnosis of illness anxiety disorder. Do you want to go for it?
Perfect.
I think it's just in. There you are. There you go. Yep.
Same?
Yeah, I'll see if you can go on to. Sorry? Oh, good question. Do you want to come and just tell me if it's showing on Zoom?
Add link line. Okay.
Pardon? Okay. That's okay. Oh, thank you. Okay. Hi, everyone. My name is Katarina, and I'm a PhD student at the University of New South Wales and the Black Dog Institute. Today, I'll be presenting to you the first study from my PhD thesis, which is on improving the diagnosis of illness anxiety disorder. But what is illness anxiety disorder? I think most of you would more commonly know it as health anxiety. Oh, how do I switch it? There we go. So what is health anxiety? I think I can safely say that we've all experienced some form of health anxiety in our lives. For example, have you ever anxiously waited for a test result or noticed a symptom on your body and decided to get it checked out? If you can't relate to any of these, have you ever been worried about getting COVID-19? All of these examples are forms of health anxiety, and they are adaptive. But what makes health anxiety excessive? Excessive health anxiety is when a person is preoccupied with their health to the point that it affects their day-to-day life. Thoughts around their health are thought-consuming, and these individuals spend a lot of time talking to their family and friends about their symptoms and seeking reassurance from many health professionals. The impact of excessive health anxiety is substantial. These individuals report a lowered quality of life, more sick days off work, greater functional impairment, and more strained relationships. They also use more healthcare services per year and double the cost to the healthcare system. So according to the DSM-4, and the DSM is the most widely used manual to diagnose mental health disorders, excessive health anxiety was known as hypochondriasis, but there were a lot of issues with this disorder. So it was very stigmatizing and people would be labeled as hypochondriacs. And it was over-restrictive and narrow, so it didn't quite capture all the individuals that were experiencing excessive health anxiety. So to address these limitations, the DSM-5, which is our current DSM, replaced hypochondriasis with two new disorders. These are illness anxiety disorder and somatic symptom disorder. So these two disorders are relatively similar. They're both characterized with a preoccupation around health, but they are predominantly distinguished by the intensity of the somatic symptoms that the individual will be experiencing. And when I say somatic symptoms, I'm referring to physical symptoms like chest pain or headache. So for someone to receive an illness anxiety disorder diagnosis, they won't have any somatic symptoms, or if they are present, they're only mild in intensity. Whereas for someone to receive a somatic symptom disorder diagnosis, they'll experience moderate to severe somatic symptoms. So given that I'll be talking about illness anxiety disorder today, I'll just quickly run through the criteria that an individual would need to meet in order to receive this diagnosis. So they'll have this large preoccupation with having or acquiring a serious disease such as cancer. And this preoccupation needs to last for at least 6 months. They'll have a high level of anxiety around their health, and they'll be easily alarmed about their personal health status. So they may see a story on the news or hear an unfortunate story from their family or friends. They'll exhibit excessive health-related behaviours, so they may spend a lot of time Googling their symptoms, or they may exhibit maladaptive avoidance, so they may completely avoid seeing health professionals or visiting healthcare settings. And the DSM-5 has also split this disorder into two subtypes. So we've got the care-seeking subtype for individuals who frequently visit care, and then we've got the care avoidance subtype for individuals who rarely visit medical settings or medical professionals. So given illness anxiety disorder is a newly identified disorder, what do we know about it so far? And there really isn't that much. We do know that it can be reliably diagnosed by a clinician, and it can detect twice as many cases than hypochondriasis. And three studies to date that have looked at whether these two disorders are different from one another has found that there's actually very little difference between these two disorders. But the differences that are there are only due to severity. So in other words, individuals with a somatic symptom disorder diagnosis will have more functional impairment, they'll be more depressed, they'll have more somatic symptoms, and they'll visit health professionals more frequently. However, these findings have only been examined in a treatment trial, so we're not sure whether they generalise to non-treatment seeking samples. So the aim of our research was to replicate this research and to extend it, but in a non-treatment seeking community sample. Specifically, we wanted to examine illness anxiety disorder demographic and clinical characteristics, its onset and course, its comorbidities and differential diagnoses, and health service use and cost. So we recruited 100 Australian adults from the community that self-identified as experiencing elevated health anxiety. So this study is part of a larger longitudinal study, but because we're still in the data collection phase today, I'll just be presenting to you the baseline results. So the baseline included an online survey as well as a diagnostic interview. Okay, so these are demographic information for the entire sample. So just to point out a few, 85% of our sample were female and were highly educated. About 50% of our sample had a chronic disease and 56% were currently in treatment for their mental health. We also looked at how many of our participants met criteria for these two disorders, and we found that just under a half met criteria for somatic symptom disorder, 12% met criteria for illness anxiety disorder, and 9% met criteria for both. We also had 32% of our participants enter the study reporting elevated levels of health anxiety, but didn't quite meet criteria for either of these disorders. We were also interested to know how comorbid illness anxiety disorder was with other mental health disorders, and we found that it was most comorbid with generalized anxiety disorder and least comorbid with agoraphobia. We also asked our participants to report when they think their health anxiety first started, so their onset and as well as their course. And so these data is also for the entire sample. So the average age of onset was 24 years, but you can see quite a large range. So we've got individuals reporting an onset as early as 4 years of age. Just over a half reported a chronic and an episodic course. 83% feared multiple diseases, and the most feared diseases were cancer, multiple sclerosis, and heart disease. We had 29% of our participants saying they sought care for their concerns. 5% said they were care avoidant. And interestingly, we had this third group that said they fluctuated between avoiding and seeking care. We did look at whether illness anxiety disorder and somatic symptom disorder were different in terms of their onset and course. And we saw that these two disorders, there were no significant differences between these two disorders. So in other words, they had a very similar onset and course. We also looked at whether these two groups were different in terms of their symptom severity. And we saw no significant differences between these groups in terms of their health anxiety severity, their generalized anxiety, and their quality of life. We did, however, see that individuals that met criteria for somatic symptom disorder had greater somatic symptoms, I guess, which makes sense, and were more depressed. We also asked our participants how frequently they used healthcare services in the past 3 months and how much they spent on these services in the past 3 months, and this excluded medical rebates. And what we found was that individuals with somatic symptom disorder visited health services significantly more and spent more out of their pockets than those with illness anxiety disorder. So just to summarise, illness anxiety disorder and somatic symptom disorder are similar in terms of their demographic information, their onset and their course. The differences that we did observe were that somatic symptom disorder was characterised with more severe depression severity, greater somatic symptoms, and more health service use and cost. But as a whole, there is little difference between these two disorders, and the differences that are there seem to be related to severity, which is in line with previous research. And a final point, which I think is also a very important point to make, is that illness anxiety disorder is less common. So what that means is that these individuals that you may come into contact with that do have this excessive health anxiety, they most likely will have moderate to severe somatic symptoms. Of course, there were limitations to our research. So majority of our sample were female, they're very well educated, and just over half were in current treatment for their mental health. So we don't know whether these findings generalise to other groups. Also, our illness anxiety disorder sample was very small. There were only 12 participants. So we don't know whether the non-significant findings that we did observe are due to a lack of power. But why is it important that we still do this research? Hopefully to improve our understanding of the features of illness anxiety disorder and inform the next iteration of the DSM-6, which is our next DSM, and develop our scientific understanding, our research, and the development of targeted treatment approaches. finally, I'd like to acknowledge my two amazing supervisors, Jill and Elisa, and our two clinical research officers, Emily and Britt, who helped conduct some of the diagnostic interviews. Thank you.
Can you tell us a bit about?
Yeah, sure. So I was involved in in conceptualizing the study and designing it, of course, with the support of my two supervisors. I did the ethics application. I did a social media strategy with the Black Dog Institute to recruit the participants. I created all the study materials like the online survey and conducted majority of the interviews. Some of the interviews that were a little bit more riskier were done by these two, by Emily and Britt, just because they are clinical psychologists, so they were able to deal with the risk. Yeah, and I've been analysing the results and writing up the research.
Thank you.
Yeah.
Thanks for a great talk. I just have a general question about illness anxiety disorder. Do you think these people are more likely to get sick because they are anxious and stressed and immunosuppressed? Has that been looked at?
Yeah, I think actually there was one study, and I read it a long time ago, that looked at people who have, it was more general, excessive health anxiety and those who don't, and had a look at whether they actually do end up having more medical conditions or end up being more sick. And I think the findings were kind of surprising, and they said that they don't. So that worry doesn't necessarily cause that, more somatic symptoms. But I mean, I did look at that a long time ago, but from memory, that was the findings. Yeah.
Thank you.
Okay.
Hi, Katarina. Thank you for your lovely presentation. I really liked your graphic design of your slides. It was very beautiful. Thank you. I just have a question about the somatic symptom disorder and the illness anxiety disorder. So you presented very similar results. What is your view on the DSM-6? Do you think that those conditions should be classified as separate disorders or disorders on the same spectrum?
Yes. So my opinion, which is in line with my supervisor's opinion, is that the current DSM has put this arbitrary line between illness anxiety disorder and somatic symptom disorder, not really based on anything. And so the idea is that we want to combine those two disorders into hopefully illness anxiety disorder. And also they currently in the DSM sit under this category called somatoform disorders, with all these other mental health disorders involving pain. But there's emerging research to show that illness anxiety and somatic symptom look and feel more like an anxiety disorder. So hopefully with more research, we would also like to put them in the anxiety disorder section, because they do share a lot of features with the other disorders there. And they respond to treatment similarly to other anxiety disorders.
Thanks, Katarina. Great talk.
Thank you.
You mentioned that your cohort was mostly well-educated. What sort of impact do you think education might have?
Yeah, that's a very good question. And one thing I didn't bring up, which I did find in my study, was that it was interesting that the illness, what drove the high education was the illness anxiety disorder group. So they were the more educated ones than the somatic symptom disorder. And one hypothesis, and obviously I don't know if it's accurate, is that we think maybe those who have these moderate to severe somatic symptoms are so debilitated by their symptoms that they weren't able to do further education, maybe. I don't know. I'd love to talk to them. And so maybe that's the result, could be driving that. But yeah, it was interesting that those who don't have the somatic symptoms had high levels of education. Yeah,
Thank you.
that's okay. Yeah, thank you.
Our final speaker today is Hannah, who's looking at school outcomes in children with prenatal drug exposure, data linkage study of an extremely large number of children. Go to the next slide, which should be over there. Yep.
Perfect. So good morning, everyone, and thank you for the opportunity to speak. Today I'll be presenting findings of my research project, Out-of-Home Care Reduces Risk of Poor School Outcomes in Children with Prenatal Drug Exposure, or PDE. PDE is a global public health problem and refers to babies who are exposed to maternal drug use during pregnancy. Many infants with PDE experience drug withdrawal or neonatal abstinence syndrome, NAS, after birth. Untreated, NAS can result in seizures and death. However, short-term outcomes have significantly improved, and babies are typically discharged home after a nursery or NICU admission following delivery, but are in an otherwise healthy condition. PDE is a growing issue, and literature has shown a 40-fold increase over the past 20 years, which has a significant cost to healthcare systems and broader social and economic implications. We know that exposure to toxic substances has direct effects on the developing fetus, and previous studies have shown increased risks of developmental delay, cognitive impairment, and a range of mental health and behavioural problems. Our previous linkage studies also showed increased risks of morbidity and mortality and poor school outcomes up to Year 7. This is critical as we know that education is one of the key indicators of success, both for individuals and society. Education improves health and well-being and results in lower rates of crime and welfare reliance. Conversely, school failure can have detrimental and lifelong effects. Children with a history of PDE often experience multiple adverse events during childhood and are much more likely to require community services support and out-of-home care. Out-of-home care is an indicator of substantiated child risk and includes children in foster care with a carer not known to the child and kinship care with a relative or community member, particularly for First Nations children. Children in out-of-home care face a number of challenges and typically have poor school outcomes in comparison to the general population. However, for children with PDE whose home environment is already toxic and chaotic, the increased support, health surveillance, and access to additional resources provided through engagement with out-of-home care may offer stability, enhance educational engagement, and support learning. The PDE population is mobile and difficult to follow over time, and there are currently no previous studies looking at school outcomes beyond Year 7 and no studies looking at the effect of out-of-home care for these vulnerable children. This led us to our question as to if out-of-home care changed educational outcomes for children with PDE. So our aim was to determine the relationship between PDE, out-of-home care, and school outcomes, with a hypothesis that out-of-home care would improve school results in children with PDE by way of increased surveillance and support, and that kinship care would be more effective for First Nations children. Our study was a retrospective population-based cohort study of all children born in New South Wales from 2001 to 2020. Educational outcomes were assessed using NAPLAN data, which is a nationwide compulsory curriculum-based test. Data linkage was performed using a data linkage service, including perinatal data, the admitted patient data collection, the NAPLAN dataset, and the DCJ Kids dataset, amongst others. Results were de-identified and linked using a unique number identifier. For those who don't have school-age children or who are too mature to have sat the NAPLAN themselves, NAPLAN testing is conducted at years 3, 5, 7, and 9 and involves testing of 5 different domains. Each child is given a raw score, which is converted into a band score. The national minimum standard refers to a predetermined benchmark of skills expected for that child's age. Children who score below this level have not achieved expected learning outcomes. This is a flowchart of our study population. You can see that over 900,000 children had linked NAPLAN data available. Hospital diagnostic coding was used to identify the PDE population, which included babies with neonatal abstinence syndrome and newborns affected by maternal drugs of addiction. There were over 3,800 children in the PDE cohort and almost 900,000 children in the non-PDE cohort. We then used DCJ data to determine which of these children experienced out-of-home care during the study and which did not. There were important differences between the PDE and non-PDE population, and mothers of children with PDE were younger, more likely to have poor antenatal care, serious mental illness, to smoke, to face social disadvantage, or to be of First Nations background. Similarly, infants with PDE were more likely to be low birth weight or born premature, to have lower APGAR scores, and require admission to neonatal intensive care with a longer length of stay. Looking at other demographic characteristics, PDE children were more likely to attend public school or be a First Nations background and had parents who were less likely to be educated or employed. Importantly, almost 50% of children with PDE experienced out-of-home care in comparison to only 1.4% of children who did not have PDE. Looking at NAPLAN results, we found that children with PDE were 2 to 3 times more likely to be below standards across all domains and all year levels. This graph shows the percentage of children who were below standards in at least one domain in each year. And you can see that PDE children, shown in green, were much more likely to be below standards. In year 9, almost 70% of children with PDE were below standards, compared to only 29% of children without PDE. These tables show the proportion of children who were below standards in each domain, and you can see that PDE children were significantly more at risk across all domains, and that this risk continued into the higher education years. We looked at the mean raw NAPLAN scores, and you can see that children with PDE scored significantly below the non-PDE cohort, whether they received out-of-home care or not. They were consistently more than 2 years behind their peers, and looking at writing scores, children with PDE had scores in year 9 that were lower than other children in year 5. Using regression analysis, we found that PDE and out-of-home care were each independently associated with a reduced chance of school success in year 9, even when adjusted for multiple potential confounders. Children with PDE were 43% less likely to be above standards, and children in out-of-home care were 39% less likely to be above standards. There were a range of other factors associated with poor school performance, and we showed that parental education and employment and social advantage increased chances of success. We know that the interaction between these factors is complex, and to better understand the potential causative roles of PDE and out-of-home care, we undertook causal mediation analysis. This very complex map shows our exposure, PDE, the outcome, NAPLAN results, and our mediator, out-of-home care, shown in the middle. We adjusted for a range of confounding factors known to affect school outcomes, which are shown in the periphery. This analysis broke down the total effect of PDE on school results into components to isolate the effect mediated through out-of-home care, the natural indirect effect, which is shown in green, and that mediated directly by PDE, the natural direct effect, shown in red, using counterfactual analysis. We found that out-of-home care mitigated the increased risk of school failure conferred by PDE. That is, for children with PDE, out-of-home care was protective for school performance. In year 9, 97% of the total effect of PDE on school failure was mitigated by out-of-home care. For First Nations children, kinship care was significantly more protective than other types of out-of-home care, mitigating 93% of the total effect, whereas any out-of-home care mitigated only 58% of this effect. There are limitations of using record linkage and of relying on hospital coding for diagnosis, and we know that maternal drug use is underreported. We also know that the experience of children in out-of-home care are extremely varied. Some children have a single short placement, whereas others may move in and out of care or between placements over long periods of time. Other unmeasurable factors such as parenting styles and other types of trauma experience would also influence school results. However, this is the largest population-based study looking at educational outcomes of children with PDE, and the only study to date that has been able to assess school outcomes throughout childhood or the influence of out-of-home care. Our results show that the increased risk of school failure conferred from PDE continues through higher education years and is potentially modifiable if the child receives additional supporting services initiated through child protection contact. Our approach must be nuanced and it must be culturally sensitive for First Nations children. We have shown that all PDE children need support, and interventions to provide structured and long-term support to biological families and educational providers is critical. By introducing specific support programs in the PDE population, we have the opportunity to improve health and wellbeing, to reduce significant economic and social burdens, and to improve long-term outcomes for these vulnerable children and their families. Thank you, and I'd like to thank my research supervisor and Julie Uebel and the rest of the research team as well.
Thanks, Hannah. Could you just let us know about your role in the study first?
Yeah, so I was involved with Julie in the initial planning and conceptualization of the project. And then when we got the data, I did the data cleaning and variable sorting, as well as all of the analysis. And and writing of the project, and then also had some statistical advice and help mostly with the causal mediation analysis.
Thank you very much. Questions, Ken?
Thanks, Hannah. How did you define perinatal drug exposure, both in terms of actual drugs and dose? And has there been any attempt to look at a dose-response relationship between exposure and these outcomes?
So we used the ICD-10 Australian modification classification, which was based on hospital coding. So we included any baby with the NAS diagnosis, which was a P96.1, or the newborn affected by maternal drugs of addiction, which was P04.4. We weren't able to say exactly what type of drug that was used by the mum or how much. But we know that mothers that use more drugs, and particularly opioids, their babies are more likely to withdraw. We also know that in Australia in particular, there's use of many other drugs, and that not all babies will withdraw, which is why we used both diagnostic codings. We were able to identify mothers that were subsequently identified to have used drugs, but their babies weren't identified. And we were able to exclude those mothers because we weren't able to identify the babies at birth. And we also were able to exclude mothers who used alcohol and whose babies were identified as having fetal alcohol spectrum disorder, but did not have the PDE diagnosis.
What about milestones? If the consequences are more severe, does delayed milestones in the first couple of years impact on how they perform later, irrespective of how you manage them?
As in how we manage them in
So you have the you have the initial syndrome.
Yep.
Some have no delayed milestones.
Yep.
Some do, maybe. Does that impact on, say, NAPLAN scores later on?
That would be an interesting study to perform. And if we were able to get that sort of early childhood information about milestones and link it in with the later NAPLAN results, that would be something that I think would be quite useful. At the moment, that data doesn't exist.
Right.
But one could suspect that children who are behind early in life do go on to be behind in school as well. So I think that's one of the important things, is to target children from an earlier age.
Yep. H.
Very interesting study. I just wondered, I mean, it's clearly difficult to separate the PDE versus out-of-home care because it's a very similar cohort. Do you have an idea of the magnitude of the effect that out-of-home care has? Because you sort of suggested that out-of-home care reduces the overall risk that PDE gives. Do you know how much of an effect it has?
So in our Year 9 cohort, it reduced the risk of that the PDE conferred on school results by 97%. So it pretty much reduced the entire effect. In some of the other years, those numbers were a bit lower. And we don't know whether that's because of the time effect of out-of-home care, so whether the children, once they got to Year 9, had been in a stable placement for a longer period of time. But we would need to do more studies to actually look at the quality and types of out-of-home care that the children were experiencing.
How do you explain the PDE and out-of-home care both independently associated with use NAPLAN?
Yeah. So for the general population, if you've got children who don't necessarily have exposure to adverse events or trauma in childhood compared to children in out-of-home care, the out-of-home care group in comparison to the rest of the population is already a vulnerable and high-risk group that have poor school outcomes. However, for our PDE population, we know that the kids that all of the children are exposed to adverse events and trauma. So the children that do not receive out-of-home care actually have less support, less health surveillance, and less intervention than those that do.
Hannah, thank you very much. So that was wonderful. 4 great presentations. Thanks to all of the presenters. So now, if you head outside, there are posters to be viewed, followed by lunch, but posters first, then lunch. Thank you all very much.